you know, there's remarkable advances and there are a lot of evidence of the success with cryoablation, the way it has simplified the procedure. It's a dramatic change in the way we approach atrial fibrillation. And I would like to request Dr. Anil Saxena and Dr. Amit Vora to take over from here, who will chair the proceeding of this talk. Anil?
Yeah, thank you, Dr. Narasimhan. It's indeed a pleasure to welcome everyone to this symposium on cryoablation. So I think it's something that that's very important, and we all look forward to. We have an very eminent faculty today. So without much ado, I think we can begin the program. And the first talk is by Dr. Sai Ramanarayanan, and he will be talking to us on biophysics of cryoablation. Dr. Sai, please.
Thank you. To such of you who don't know Dr. Sai Ramanarayanan, he is the field clinical specialist from Minneapolis, and he has been pioneering a lot of educational efforts in taking cryoablations to different parts of the globe. And we had the pleasure of interacting with him a couple of months ago, and we would request him to talk about biophysics of cryoablation. Sai, yours. Can you play the video? Wait a minute, the video. This one. No, please. No. The text is.
Good evening, everyone. I'm Sai Ramanarayanan, and I'm the field education specialist with Medtronic. And today I'm going to be talking about the biophysics of cryoablation. Today's agenda is going to include RF versus cryo, a little bit about the Joule-Thomson effect, mechanisms of cell death with cryo, and finally, we'll be talking about dosing strategy. First, what's the fundamental difference between radiofrequency and cryoablation? RF adds heat, causing direct cellular injury with resistive heating, conductive heating, which leads to hyperthermic coagulation necrosis. Cryo removes heat, causing direct cellular injury with the advent of hypothermia, ice formation, apoptosis, and necrosis. So how do we get these really cold temperatures with cryo? The fundamental principle that allows cryo systems to be used as an ablative energy source is known as the Joule-Thomson effect. Joule and Thomson were two physicists that knew that all natural gases can be transformed into liquid by cooling them to a specific temperature. Likewise, if the liquid was rewarmed beyond that temperature, it would turn back to gas. What was unique to their observation is that gases can be transformed into liquid by compressing them with a specific amount of pressure. However, once the pressure is released, the liquid transforms back to gas, bringing its temperature down to its boiling point. So this is exactly what we do in our cryo console. So we have pressurized liquid nitrous oxide, which is now released to the distal portion where the balloon is located. Within the balloon, there are about 8 ports through which the liquid nitrous oxide comes out, expands to become gas, and during this expansion, the temperature drops to the boiling point of liquid nitrous oxide, which is minus 89.5 degrees centigrade. And that's how we achieve really cold temperatures at the tip or at the balloon. So here's an example of this Joule-Thomson effect. Inside the bottle, there's pressurized alcohol and its temperature is 31 degrees centigrade. Once the bottle cap is removed and the pressure over the alcohol is released, it transforms to alcohol vapor, and the temperature, you will notice, will drop to 19 degrees centigrade. So finally, let's talk about our cryoablation system. Cryo always leads with a wave of hypothermia. So you have this really cold wave going in, causing the cells to become dormant, and it causes electrical dormancy first. And once the temperature drops to about lower than 0 degrees to minus 15 degrees centigrade, there's ice formation, extracellular ice as well as intracellular ice, which leads to cell death. And finally, you have microcirculatory failure and subsequent vascular stasis during thawing. These complex mechanisms occur in the sequence of freezing, thawing, hemorrhage and inflammation, and finally you have replacement fibrosis. So these are the phases of mechanisms of cell death that occur with cryo. So initially, as the temperature goes down to 0 degrees centigrade, at about 23 degrees centigrade is where the cells become quiescent. So you have metabolic slowing, biochemical uncoupling, disruption of cellular components, and vascular constriction and reduced blood flow. And all these effects up to 0 degrees centigrade are reversible with cryoenergy. And once you go below 0 degrees centigrade, that's where extracellular and intracellular ice form, which lead to cell death. Extracellular ice leads to mechanical cellular damage through the formation of a hyperosmolar extracellular environment, which leads to the loss of intracellular volume and hyperosmolarity. So intracellular ice leads to mechanical organelle damage, and it also causes cessation of local circulation. So as the temperature begins to thaw to 37 degrees, there's ice recrystallization, prolonged hyperosmolarity, vasodilation, hyperemia, and increased vascular permeability and endothelial disruption, which all lead to enhanced cell death. Finally, you have apoptosis, microcirculatory failure, inflammatory response, as well as fibrosis that set in hours and days after ablation. And these lead to lesion maturation and scar formation. So just to give you a recap of the biophysics of the cellular response, you will see here as the temperature drops to 23 degrees, you have electrical dormancy achieved and the cells will stop contracting. And this effect is reversible. So if you warmed up the temperature, the cells will get back to normal. And you see extracellular ice formation about minus 15 degrees centigrade, and that'll follow. Following that, you'll have intracellular ice that will form at around minus 40 degrees centigrade. And the necrosis or non-viability, that temperature is around minus 20 degrees centigrade. So now let's look at the characteristics of the cryo lesion versus the RF lesion. On your left, you have a cryo lesion, and on the right, you have an RF lesion. And these were done in a canine model, and these are lesions after 7 days of ablation. So you can see that the cryo lesion, the lesion is pretty well demarcated, and you have very minimal thrombus formation. The endocardium is intact, and the fibrosis is complete within 7 days. In the RF lesion, you see that there's a disrupted endocardium, there's thrombus present, and hemorrhage still occurring, and the fibrosis is just started after 7 days. So you see how big of a difference there is between the cryo and an RF lesion after 7 days post-ablation. So next, we will move on to dosing strategy. It's important to consider the role of distance, time, and temperature whenever you're talking about dosing. So how long you ablate, how low the temperature goes, and how much the distance is between the balloon and the peripheral structures all matter when it comes to efficacy, safety, and efficiency. So just to give you a little bit of an orientation to the history of dosing, remember that we are now in our 3rd generation cryo balloon. The difference between the first and the second generation cryo balloons is that we had only 4 ports in the front end of the balloon. In the first generation, which did not lead to even cooling on the sides of the balloon. However, in our 2nd generation balloon, we corrected that by including 4 more ports. So we have 8 ports in the frontal end of the balloon, which leads to even cooling of that frontal hemisphere of the balloon. So our first generation balloon required a 240-second freeze, which was the recommended, and people have done up to 300 or 400, and you can see that once you go above that 300 mark, you can have atrioesophageal fistula formation. And once you have, once the second generation came about, the ablation time significantly dropped to about 3 minutes on an average, and people were going as low as 90 seconds in recent times. So there was a wide range of ablation strategies that people use. However, what should guide your ablation strategy should be the timed isolation. Let's take a brief look at the history of timed isolation studies. There were 3 early studies, and the landmark cutoff at 60 seconds to examine TTI were all established using these studies. Seconte et al. Examined 29 subjects having repeat ablations. They showed that the patients with reconnected pulmonary veins had longer timed isolation compared to isolated PVs. And they showed that a timed isolation of less than 60 seconds was a very strong predictor of durability. So it was constituted 86.7% sensitivity and 86.2% specificity to predict long-term PVI. Ariana and colleagues showed a similar thing in 2016, examined 71 subjects having repeat ablations in multicentric review. They showed that the reconnected PVs again had longer TDI compared to isolated PVs, 67.6 versus 39.1, and timed isolation less than 60 seconds was had good sensitivity and specificity to predict long-term PVI. And the same thing was established by Seconte and co-workers in 2016, looking at 26 subjects. And finally, Ariana and co-workers did a cryo dosing study. This is kind of the study that we more often than not use in most laboratories across the US. So their strategy was they looked at 3 different routes. So if they had a time to isolation of less than 60 seconds or less or equal to 60 seconds, then they did the time to isolation plus 2 minutes and a single freeze strategy. And if their time to isolation was greater than 60 seconds but less than 90 seconds, they would do time to isolation plus 2 minutes and an additional 2-minute freeze. Their third strategy was if their time to isolation was greater than 90 seconds, then they would stop and reposition the cryo balloon. And if time to isolation cannot be measured, they did a 3-minute application followed by a 2-minute secondary cryo application, and they would assess exit or entrance block after that. So the key findings of this study, which was done in 755 subjects, was that when you use the dosing strategy, it was associated with a significantly shorter and fewer applications without compromising on the efficacy of the procedure. And it reduced overall ablation, fluoroscopic utilization, left atrial dwell time, and total procedure time. So you can see that there was a significant reduction in all of this, and as well as complication rates were really low compared to control when you use the dosing strategy. And this is the one that's being widely used. And recently, my colleague Michael Getman kind of looked at, he published his paper in 2019, looking at the relationship between time to isolation and freeze duration. And he generated a computational modeling of dosing for our Arctic Front Advance as well as Arctic Front Advance Pro balloons. And what he showed was that he looked at 2 different time points. So one was time to isolation to reach electrical dormancy, which occurs around 23 degrees centigrade. So that's the time when the cells go dormant, and a time to isolation to reach non-viability, which is around minus 20 degrees centigrade. So using these 2 isothermal temperatures as the guide, they developed this computational model. And when they looked at their results, it kind of corroborated the 3-minute freezes that we've all been doing. So interestingly, if you looked at tissue depth and compared it with the time to isolation to reach electrical dormancy versus time to isolation to reach non-viability in both these second generation balloons, which is the AFA or Arctic Front Advanced versus the Arctic Front Advanced Pro. Both of them had similar results. So if you had a tissue depth of 0.5 millimeters, you reach time to isolation or electrical dormancy in about 33 seconds. And about 40 seconds, you reached non-viability. So, which is what you want. So interestingly, in this data, you can look at about, if you were freezing for about 3 minutes or 161 seconds, close to 3 minutes, you reached a depth of 3 millimeters and your time to isolation was close to 60 seconds, which is kind of corroborating with all the data that we've seen that a time to isolation of 60 seconds is a very strong indicator of durable pulmonary vein isolation. So finally, the closing takeaways from this part of the presentation is time to isolation less than 60 seconds is the strongest predictor of durable lesion for cryoablation. Time to isolation is the only real-time marker of circumferential PV isolation. We don't have any others. When time to isolation is not available, there are other strong indicators to guide your ablation, like nadir temperatures. So if you have minus 40 by 60 seconds or a thaw time to 0 seconds, these can be pretty strong indicators that you might have achieved durable PVI. With time to isolation less than 60 seconds and in combination with time to 0 of greater than 10 seconds, there is less than 1% chance of reconnection in those veins. And if both these parameters are not met, then there's a 75% chance of reconnections. Finally, time, distance, and temperature are key parameters to adjust to keep the peripheral structures safe. So in order to achieve a safe, efficient, and with a procedure with higher efficacy, we need to make sure that we are paying attention to all three parameters: time, distance, and temperature. And with that, I'll end my talk and take any questions later. Thank you.
Hello, Sai.
Yeah.
Hello. That was a wonderful overview of the biophysics of cryoablation. And, one of the practical questions which I have is that you very nicely pointed out that TTI of less than 60 seconds is important to predict outcomes. A basic question to a person who has not done cryo is, what happens, what can you do if the TTI is more than 60 seconds? Can you do a repeat cryo? Should you do a repeat cryo? Is that advisable?
No, it all depends on how thick your tissue is, right? So if you have good occlusion and your time to isolation is greater than 60 seconds, then the possibility of that tissue being thicker, so that's kind of telling you that maybe that area you're ablating is thicker than probably, from that data, it's 3 millimeters was the thickness for 62 seconds of, the computational modeling. So it can indicate if you have good occlusion, if you've looked on ice and you have occlusion, but your time to isolation was longer than 60 seconds, then you could try getting more antral and doing another freeze where the thickness of the tissue might be thinner. So that's some of the things that you can consider while you're ablating. And also let your peripheral structures also guide you. So if your esophageal temps are dropping pretty rapidly and in a short period of time, that's also indicative that if you're hitting the esophagus already, that means that the cold has penetrated that thickness of that tissue. So it's not straightforward as a one-shot solution to everything, but it's just considering time, distance, and temperature, and letting those parameters guide you in your ablation.
Thank you. Anil, Any questions?
Yeah, I think no, but would the second lesion lead to an overdose? Obviously, if you, as you pointed out, that fistula can form if it's a very long duration lesion, at least in the earlier iteration of the device. So, will a second lesion can be harmful in that sense?
So it's an excellent question. So what they found with doing same duration freezes is that it does not really, increase the lesion volume, but pushes the ice formation to the border of the original lesion. So freeze does not necessarily mean you're going deeper if you're doing the same duration of time the second time around. So all it does is that it pushes that boundary of ice formation towards the periphery of the lesion. So it does not necessarily lead to extra damage, in terms of depth. So in order to go deeper, you have to go longer.
Thank you, Sai. Very good insights. Thank you so much. Excellent talk.
We'll have the next talk. Amit?
Yeah, so, yes. So we can proceed to the next presentation. And may I invite Dr. Oras Atreya from AIG Hospitals. He will be talking on emerging clinical evidence for AF ablation. Dr. Narasimhan, you can introduce him.
Thank you very much. Oras is a colleague of mine, and he has completed his training from University of Michigan, Ann Arbor, from where he came and joined here as an electrophysiologist, and he'll be talking to us about the clinical evidence of catheter ablation of atrial fibrillation. He has significant experience in this technique.
Thank you. Thank you very much, Dr. Narasimhan, for the kind words. And it's my pleasure to be part of this forum here to speak about catheter ablation for AF. So, this talk will be not just about cryo, but about all of the techniques for catheter ablation of AF, just to set perspective. And then further talks will be specifically about the utility of cryoballoon. So we'll briefly speak about the epidemiology, the trends, and understanding the substrate for AF, because this has several implications for catheter ablation. We'll also just get a historical perspective of the development of AF over the last 2 decades and the remarkable progress that we've had. And then we'll talk about each of the techniques and the important papers that have come about. So everyone's seen this slide at some stage. Very important circulation paper from Dr. Sumit Chugh and group looking at the global AF burden. And then it shows that the burden of AF is much higher in the North American region, lower in the Asia Pacific, specifically the Indian subcontinent area. But the temporal trends in some other studies indicate that we are now seeing an uptick in the atrial fibrillation incidence and prevalence. And if you look at the US population estimates, either from the Kaiser Permanente group or the Mayo group, it is anticipated that the AF burden by 2050 is anywhere between 5 to 15 million people. So this is an extremely prevalent problem, and we already see that catheter ablation for AF is a very dominant part of the EP electrophysiology practice. So if you look at the natural history of atrial fibrillation, we have risk factors, hypertension, heart failure, which start to impact the atrium, and there's atrial remodeling. And people who go through periods of predominantly sinus rhythm with paroxysms of atrial fibrillation, as the atrium remodels, that's when we have this spectrum overlapping a temporal spectrum, which is the paroxysmal, persistent, and permanent AF. That's how we classify these based on the duration of atrial fibrillation. But it very much correlates with the underlying atrial remodeling and the substrate. And then at one point, when the substrate is just fine and the milieu in the left atrium is more suited for just permanent atrial fibrillation, that's the point where our interventions for catheter ablation are likely to definitely fail, and earlier interventions are helpful. This is a recent review in the New England Journal of Medicine by Greg Michaud and Bill Stevenson from Vanderbilt. A very nice illustration showing the changes in the atrial anatomy anatomy grossly, but also histopathologically, which allows for micro re-entry. And this again correlates with our clinical manifestation or the clinical profile of paroxysmal to early persistent to long-standing persistent to permanent AF, which is just, no further attempts. So those patients with permanent AF and almost no episodes of sinus rhythm have extensive atrial fibrosis. And if you look at data from the DCAF study by Dr. Marouche and group when he was at Utah, MRI pictures of the atrium demonstrates extreme amount of scarring. And that correlates with left atrial dilatation that we see on echocardiography, and then evidence of heart failure that we see in these patients with permanent atrial fibrillation. So this is a very nice slide from the Canadian Journal of Afib guidelines, which shows that when atrial fibrillation is a new problem, it's a paroxysmal episode, paroxysmal problem, people just having episodes of atrial fibrillation through the year. Triggers are very important in the genesis of AFib, and as we all know, pulmonary vein triggers are the most likely triggers for AFib. But as this remodeling happens, triggers are far less important, and the substrate, a lot of it is that AF-induced substrate. We've talked about the remodeling, but also age-related, substrates that are not modifiable, and several lifestyle risk factors that also accumulate over time start contributing to this problem. This is actually another useful newer sort of classification or assessment of atrial fibrillation, which I think has implications for catheter ablation. So we, instead of just thinking about AFib as paroxysmal, persistent, or permanent, this framework by Greg Lip and colleagues, the 4S framework, which is to understand stroke risk. So this has no implication for ablation. Stroke risk we estimate using the CHA2DS2-VASc score and anticoagulate. But then all of the three S's, the symptoms, is the patient very symptomatic or asymptomatic? How severe is the AFib burden, irrespective of symptoms? And what is the underlying substrate? All of this has implications for catheter ablation. So someone who doesn't have a lot of symptoms, if you put it into the scoring system, that's not in favor of ablation, but someone who's very symptomatic, I think would benefit from ablation irrespective of the burden or the substrate. Similarly, if someone has a lot of AFib burden, irrespective of dominant symptoms, they would also benefit from AFib ablation. And someone with a lot of substrate, this actually, if there's more substrate, it implies that our success with ablation is going to be lower. So the perfect patient for ablation is someone who's highly symptomatic with a moderately severe AFib burden, but not a lot of substrate. These are the people that catheter ablation is going to be really successful, and that's these people with the green. So thinking of this framework in our assessment as electrophysiologists helps us understand who would benefit from rhythm control using catheter ablation and those without. And again, we won't talk a lot about this, but not to lose sight of the fact that management of AFib ought to be holistic, not just catheter-driven. But our talk and our symposium today is directed towards catheter ablation, and that's where we'll move at this point. So 2 slides on the current indications for the, or the consensus statement for ablation of AFib, and this is a consensus document from the American Society, the European Society, Asia Pacific Society, and this is what all of us refer to. So symptomatic AFib, really, one has, AFib ablation predominantly is for symptom control. And particularly in AF patients, I think the data now suggests that it can be it's a class 1 indication, can go upfront to catheter ablation or compare it vis-a-vis to drugs. So that's, patient preference model. This is kind of like treating chronic stable angina with stenting. Symptoms drive the ablation here. In persistence, you have to be a little more careful choosing. I think it's reasonable to have the patient fail an antiarrhythmic drug before going to catheter ablation. Early persistence, you would treat more like paroxysmals, but late persistence, you would treat like permanence, where you try a lot of drugs, at least 1 or 2 drugs, and then go to catheter ablation with the knowledge that you may need more than one ablation procedure. In terms of the underlying comorbidities, again, this is a slide from the Canadian journals. The data now suggests, and we'll go over some of this data. Data suggests that if you have heart failure with a low EF, an early catheter ablation approach is useful. Underlying coronary disease has implications for the type of antiarrhythmics we choose. Class 1Cs are out. But in the patients without heart failure or coronary disease, the class 1Cs versus catheter ablation are both class 1 indications. So flecainide and propafenone with the pill in the pocket strategy versus catheter ablation. So that's a discussion the electrophysiologist and the patient needs to have. And in our country, the patient's finances also play a role in this decision making. So let's switch and get a brief idea of how catheter ablation has evolved over the years. So I'll quickly go through these slides, but the genesis of percutaneous ablation is in the success of the Cox-Maze 3 procedure pioneered by surgeons at Washington University. And the idea was to cut and sew and create corridors for electricity to travel in the atrium such that there's not areas for the circuits to form. And this was the original Cox-Maze procedure where there was a full thickness inside, and then they were meticulously sewn around the pulmonary veins, around the appendage, and between the intercable lines on the right side.
Excuse me, sorry to interrupt, Boris. I think we are running behind time, so I would request you to wrap up in the next 2-3 minutes.
I'll take 10 minutes and we'll wrap this up. So the early interest then went towards ablation along the right atrium. This was Hesegire and group. Other groups at Hopkins and Michigan were also trying this in the left atrium and the right atrium, and really success here was quite low. And then the understanding of trigger ablations. Here you see a catheter inserted into the pulmonary veins retrogradely. This was before transeptal punctures for atrial fibrillation ablation. And understanding that the triggers were important. This is how ablation evolved. Then came the idea of performing PV pulmonary vein angiograms and then ablating at the ostium. So this was the segmental ostial ablation group, again pioneered by Bordeaux group and a few other groups. The late 90s then had the introduction of mapping systems, intracardiac echo that was accompanying catheter ablation. Then came the understanding that segmental ostial PVI works for paroxysmal AF, but is abysmal in terms of success for persistent AF. And the turn of the century is when antral ablation came about, because the success with ostial ablation was low. So circumferential PVI, as we know it, or the wide antral circumferential ablation, for all phenotypes of Afib ablation, started taking off, and this was a seminal New England Journal paper by Hakan Ural and the group at Michigan, as well as the Italian group. In terms of RF ablation, the other advances over the year was to consider adding things. So the question was, is PVI alone sufficient? Because success rates were not 100%. So addition of cafe ablations, of fractionated atrial electrograms to PVI showed some success in the STAR AF trial, but cafe alone did not pan out. And then further, this was an important paper in 2015 in the New England Journal. This was STAR AF2. This is linear ablation in addition to PVI, or cafe ablation in addition to PVI. Did not really yield significant benefits over PVI alone in persistent AF. So this is sort of the time when cryoballoons started getting introduced, and therefore a significant argument is that PVI alone, even for persistent AF, is the way to go, and therefore the balloon-based techniques, which essentially achieve PVI alone, are widely used nowadays. The only two other trials I'd like to mention with RF ablation that are very significant over the last 5 years, the Castle AF study showed a mortality benefit in patients with reduced EF with implanted defibrillators and CRTs. And the Cabana trial tried to look at mortality benefits for ablation compared to medical therapy in all comers with normal EF as well. This did not show a mortality benefit, but there is some issues with a large number of crossovers in the control group that went to the RF group. So a couple of slides on cryoballoon. The first study, the STOP AF study, came out in 2013 with the first generation cryoballoon. We know the biophysics of this from Sai Ramnarayan's talk. And this was paroxysmal AF versus drugs. And success rate was close to 70% in the cryo arm and just 7% in the drug arm, because these were patients who were drug refractory already. So this, this was then compared to RF, the newer technology of RF in the Fire and Ice trial, which was a seminal trial published by Karl-Heinz Cook and colleagues in the New England Journal. And this showed non-inferiority of cryoballoon vis-a-vis radiofrequency catheter with both advanced generation, but that is with irrigated tip open contact force sensing catheters. And this really has led to the current state where cryo versus RF both appear to have equal efficacy in paroxysmal AF, at least. In people with persistence, if the idea is to do more lines, then one may choose radiofrequency ablation. STOP AF first, the most recent important trial, which was using a cryoballoon up front for paroxysmal AF without using drugs. And then again, this shows a significant benefit in this group. A slide each on the newer technologies. The other balloon-based technology that's commercially available in the US and some other markets in Europe is the visually guided laser balloon. This has gone through 2 iterations, and this shows non-inferiority compared to radiofrequency radiofrequency catheter ablation. And then a lot of new technology using balloon-based RF energy is coming out. And if you look at the 6 balloon-based technologies that are likely to be in use over the next decade or so, you have a couple of cryoballoon catheters, one by Medtronic, one by Boston. The laser balloon and hot balloon is basically heated saline using radiofrequency energy. This is based on just one trial out of Japan. And then radiofrequency multi-point radiofrequency balloons, which are again single-shot technologies. These are going to flood the market, and the jury is going to be out in terms of which is better compared to the others. And finally, a slide on a pulse field ablation. Again, we have 2 companies coming out with this. There's a lot of interest in this because this has the ability to target only the pulmonary vein potentials without causing collateral damage. And I think we'll be seeing a lot of this. This may redefine once again catheter ablation for AF. And what we've learned for the last 20 years may be different. I'll end with this slide, which is a very nice timeline slide by Douglas Zipes and colleagues of the various iterations of catheter ablation. With this, I'll end. Thank you very much for the time.
Thank you, Auris. That was a very nice talk, and we'll have the questions towards the end of the session. We'll have a very interesting talk by Dr. Devi Nair, who's been a friend and mentored several people in low fluoroscopy, ice-guided cryoablation. And I would like to thank her for joining us for this session. We'll have step-by-step workflow for integrating ice in 3D mapping strategies for cryoablation. She has been a leading researcher in this field, and she'll be walking us through how to do ice-guided cryoablation over the next 30 minutes. Devi, chair is yours. This one.
Good evening, everyone. I would want to thank Dr. Narasimhan for giving me this opportunity tonight to discuss with you about my strategies that I use to have a low fluoroscopy workflow during my cryoballoon ablation. These are my disclosures. But the main disclosure today is that today's presentation is solely based on my practice and how my cryoablation program is set up. So the goals for the day is to discuss basically the strategies that I use to minimize, or maybe most of the days completely eliminate fluoroscopy during a cryoballoon ablation for Afib. And the way we achieve that is by integrating 3D mapping technology, intracardiac echo, and then using non-fluoroscopic PV occlusion strategies to achieve pulmonary vein occlusion and isolation. And what we do mostly is pressure wave monitoring and color Doppler, and we'll go through those in detail. Regarding pre-op management and testing, we bring our patients with uninterrupted oral anticoagulants, including the DOACs. Routine pre-procedural imaging is usually not performed, so we don't do CTs and MRIs, and we don't exclude patients based on their anatomy from a cryo procedure. We don't routinely do TEEs on the day of the procedure either. We assess for left atrium and left atrial appendage thrombus using intracardiac echo, usually by putting the intracardiac echo in the right ventricular outflow tract and in the left PA. Regardless of the pre-ablation vein size, we typically utilize a 28 millimeter AFA Pro cryoballoon. And even in the small atria and even in pulmonary vein sizes that are less than 20 millimeter, we try to achieve a wide antral isolation rather than ostial isolation. Regarding my approach to sedation, I routinely use general anesthesia for all my cases. These patients are not on any paralytics, so the CRNAs and the nurse, the anesthesia team is pretty in tune with the procedures. The cryo procedures are usually the first cases of the day. And because of the early completion times, for most of our ablation cases, these patients are able to go home the same day as well in our center. And we have seen our outcomes and patient satisfaction data from the same day discharge approach, and they have done really well. Regarding the equipment that we use, we almost always get access with ultrasound. I do a single transeptal approach. I have 2 additional femoral sheets in addition to my transeptal sheet, one for intracardiac ultrasound and one for a decapolar recording and mapping catheter. We use 3D mapping in all of our cases, and we use that to mainly minimize fluoroscopy and to help with catheter manipulation. The decapolar catheter is usually placed in the coronary sinus during isolation of the left-sided pulmonary veins, and then we move it to the superior vena cava for phrenic nerve pacing during the right-sided pulmonary vein ablation. For transeptal, for the cryo procedures, we usually target a low anterior approach, and that's obtained with ICE guidance. Our approach to PVI, we usually perform PVI only in our cryoballoon cases. I utilize the cryoballoon mostly just in the pulmonary veins, and we look for entrance and exit block after isolation. As I said before, we use a 28 millimeter balloon along with the 20 millimeter Achieve catheter, and that helps us get wide antral isolation. Many times we are able to isolate with a single freeze, but if we have a common vein or if we have a larger antrum, we will do a segmental approach, again guided with mapping and intracardiac echo. At the end of the procedure, we do validation mapping to make sure that we have an antral isolation. So I thought the best way to do this would be maybe do a case together. We have recorded a case, and I'll go by step as to what we do during our case. So this is a gentleman that came to us. He's 54 years old with paroxysmal atrial fibrillation. He's on sotalol and Xarelto. He has many risk factors, including hypertension, diabetes, and CAD. He's had recurrent symptomatic episodes despite being on sotalol with spontaneous conversion. And he was seen in our AF clinic for risk factor modification and referred to the AF ablation for antiarrhythmic drug failure. We actually, in our center, do cryoballoon PVI as first-line therapy in many patients without even attempting antiarrhythmic therapy, especially with the most recent data. So we start with getting 3 axes in the femoral vein, again with ultrasound guidance. But the first catheter that goes in is an ICE catheter. And I almost always use a long sheet for my ICE catheter. So it's a 45 centimeter just a quarter sheet that gets me past that iliac bend, especially if I'm using, say, a St. Jude ice, which is a little more stiff. That's helpful. I think the key to putting an ICE catheter up, you can see on the left, we're putting the ICE catheter up, is to always have that echo-free space. And you can see I'm getting into the liver there, so I'm rotating the catheter, giving it an extra curve to kind of navigate through that echo-free space. So utilizing the torqueability on the catheter and those directionality indicators, you can actually navigate into the right atrium without any fluoroscopy. And once you're in the right atrium, you can go back to a neutral position. So again, very important to make sure that we maintain that echo-free space. What you're seeing here is, again, the same thing about going up that IVC, always making sure that you have an echo-free space in front of you. Here we are by the liver, we give an anterior tilt and get into the right atrium as soon as you see the right atrium. So the next thing we do once we have the ICE catheter up is to do a baseline anatomy assessment, and mainly looking for effusion, thrombus, and just the orientation of the veins. So for that, we start off with the ICE catheter in the right atrium. I make an anterior tilt into the right ventricular outflow tract, and you can see I'm clocking the catheter here. Looking at, there's no effusion, there's no baseline effusion. This is the LV in a short axis. And as I'm clocking that catheter, you'll see the aortic valve come into view and the appendage right there, showing you the ostium of the appendage with one view of the appendage that does not show any clot. The other view that we utilize is the view where we get into the left pulmonary vein. So once we have ruled out thrombus in the left atrial appendage, we get ready for transeptal. And this is one of those steps that really gets you to whether you use fluoroscopy, you use minimal fluoroscopy or completely eliminate fluoroscopy. So for example, in this case, you'll see that what we're doing here is no fluoroscopy. So once we have the sheet in place, now we are ready to get ready for our transeptal. This is what I'm using here is an SL0 sheet. You can use more recently we've been using the VersaCross sheet, but you can use any of your routine transeptal systems. You can see that I'm getting ready to bring that sheet up. I make sure that I can visualize my SVC, I can visualize my wire, and here's the sheet coming up into the SVC. For getting ready for transeptal. Now we have already given heparin. We usually give heparin right after we get access before we even put our ICE catheter up, and we try to keep our ACTs between 350 and 400. So the next step is bringing the sheet down with the needle in place. In this case, I'm using a Baylis needle, and you can see I made the curve of the on the Baylis to kind of get me to that inferior anterior spot. So you can use a Brockenborough needle, or if you prefer, we routinely use a Baylis needle. And once the needle is in place, you can see the sheet very well. And we're getting ready to bring down the transeptal system at this point. And I'm going to drag it back just with ICE guidance. Now you can connect the needles to the Insight mapping system if you want to. We routinely don't do it because we can see it very well on ICE. You can see I'm slowly bringing it back. Once I get to the septum, I take the curves off of the ICE sheet, go back to that neutral position that shows me the septum very well, shows me that inferior anterior spot where I want to go in. You can see I'm inferior, I'm pretty anterior, I can see the appendage in certain view, and as I clock, I can see the pulmonary veins. Here is the transeptal with color. You can see the SVC. Here I'm coming down with my transeptal sheet. And again, if you have a PFO, that's something I try to avoid. So the color kind of helps with that to see if you have a PFO to start with. And here you can see I'm again back in that inferior anterior spot. And here we're coming across with the RF needle with that RF pigtail wire. At this point, once we are in the left atrium with the sheet, we are now ready to exchange for a flex cap. I routinely use a pigtail protract wire, or I use a VersaCross pigtail wire. I like to visualize. It's easier to visualize it on ice. You can use a J wire or a stiff wire into the pulmonary vein if you want, but I routinely use this because it's much more echogenic and you can see it in the left atrium much better. Here's the example of the protract wire in there. We're now getting ready to come up with the flex sheet. You can see us going up with the flex sheet. It's slow movements over the wire. The protract wire is able to maintain that. You can use an Inari wire if you need, and you'll see me crossing the septum with the flex cath sheet right there as I'm traversing the septum across. And once the sheath is across, you have two things you could do. One, you can decide you want to image from the right atrium at this point, or you can decide that you want to image from the left atrium. Through the rest of this presentation, I will show images from the right side, and I'll also show images from the left atrium. So if you do decide you want to get into the left atrium with your ICE catheter, this is the time to do that. You would, at this point, after you have crossed with your flex sheet, you would move the flex sheet back because now you have dilated that septum, and you can slide the ICE catheter into the left atrium, and we'll show you how that's done. So here is the transeptal here. Here is the VersaCross wire, which is also a pigtail wire. I have taken the flex sheet across. I have dilated the septum. Now I've pulled back the flex sheet back into my IVC. And what you're going to see me do is bring my ICE catheter closer to this and kind of slide it in. And that's again done under only ICE guidance. So we are going to come down with the ICE catheter. We are moving down. You'll see us bring the ICE catheter down, and we're going to slide across into the left atrium, and you can see now we are in the left atrium. The images once you put the ICE catheter in the left atrium are much clearer than if you image from the right side. So for example, if you have a case like this on the right side here, where you have a lot of, say, leads and you have a lot of artifact, it's very much better to image from the left side. So see, if you image from the right, you get a lot of artifact, and you can see as I cross into the left, you can see how well the images are on the left side. So I try to go into the left side in majority of my cases. In rare situations where, say, if there is a thicker septum, or if I have a ASD closure device or a pericardial patch or previous closure, and I have difficulty getting across, then I don't. But majority of the cases, I actually take my ICE catheter into the left atrium, and it's very easy to do. So once you're in the left atrium, we do a assessment of the pulmonary veins. As I said, I don't routinely do CTs. So we actually use ICE to identify the number of veins, the type of veins, the orientation of the veins, and we use color Doppler to assess that. And so this is the example of the color in the left superior pulmonary vein here. So you can see the color flow in the left superior pulmonary vein. I'm counterclocking the ICE. You can see the appendage come in there, and now you can see the left superior and the left inferior pulmonary vein show up on this left side. As I clock that ICE catheter in the left atrium, I'm going to see the right inferior pulmonary vein and the right superior pulmonary vein show up very well. And these are sometimes a little bit harder to image from the right atrium. The other advantage is that you can actually see all the branches of these pulmonary veins as well, especially when you're getting ready to cannulate with the chief. So once you've identified the veins, now we are getting ready to get the flex sheet back in. So that we leave the ICE in the roof of the left atrium, around the septum. You can see I'm always in an echo-free space when I'm in the left atrium with the ICE catheter, and then I'm going to bring in the flex sheet back. So here's my pigtail wire. You can see I'm going to move in with the flex sheet back into the left atrium, since I had already taken it back to allow for ICE movement forward. So now my flex sheet is in, my pigtail wire is out, and you can see the image of the left superior pulmonary vein. Here's the appendage, and you can see it's almost straight directed into the left superior pulmonary vein. So the next part of the procedure is insertion of the cryo balloon. Obviously, we connect that flex sheet to a irrigation system, and then we're getting ready to connect or go in with the cryo balloon. We prep the cryo balloon. There's a marker on the cryo balloon. There's a white marker that allows you to know how much of the balloon you can go in before it comes out of the sheath. So we go in without any fluoroscopy. You can see that white marker right there, and then we go up with the balloon. And once we are at the tip of it, or at the first white mark, we stop before we advance any further. The next thing we do is advance the ACHIEVE catheter. And what you're going to see here is the balloon coming up there. You can see I'm at the first white mark, and I'm going to bring in my ACHIEVE out. And my mapping specialist is ready to map as well. You can see the ACHIEVE is coming out in the mid-left atrium. Now, this imaging is from the right atrium. So you can still see it from the right atrium. You don't have to go to the left atrium. But obviously, I'm going to show you what the left atrial image would look like. You can see here, this ICE catheter is in the left atrium. You can see the ACHIEVE catheter coming out. We have flush attached onto the flex, or flush attached onto the flex sheath. And you can see the images are much clearer. This is kind of what our setup looks like. We come up with the ACHIEVE. We could quickly use the ACHIEVE to get a quick map of the left atrium. You can do a pre-map just to identify. Sometimes we'll actually map as we go along. So you can, here I'm doing a very quick map of the left atrium, just doing an anatomical map. This is not a detailed voltage map. We are coming in with the decision that we're doing a pulmonary vein isolation. So the whole idea is just for orientation purposes. We're doing a very, very quick map. This is kind of the setup for our lab as well, for the screen that we're looking at. We usually have a recording system that we can see the signals. We have ICE, we have mapping, and then we have a hemodynamic screen that's going to show us the pressure wave monitoring. The next thing that we do after we have a map is putting the CS catheter up. I almost always start in the left superior pulmonary vein with my ablation, go to the left inferior, then go to the right inferior, and then go to the right superior. So I come up with my CS catheter. I routinely use Insight system for my cryo cases because I can see these catheters in the Insight system without having to open a proprietary catheter. I can see the ACHIEVE and I can see the CS catheter. So here I'm putting the CS into the decapolar catheter into the CS and watching it on the signals here, as well as on the mapping system. If I can't see it well, I'll actually look at on ICE as well. So at this point, we're ready to engage the left superior pulmonary vein. I'm going to show you images from the left side here. You can see the pulmonary vein with the color Doppler. You're going to see me come out with the ACHIEVE catheter first. You can see the ACHIEVE is coming out. I'm engaging the left superior pulmonary vein with the ACHIEVE. I'm going to make sure that my sheath and my ACHIEVE are coaxial to the left superior pulmonary vein. And then when we're ready, we're going to advance the balloon in. So you're going to see me once the ACHIEVE is in the pulmonary vein. I'm getting ready to move the balloon in. You can see I can clearly see the coaxiality of my sheath and my balloon on my intracardiac echo. And I try to make sure that at least 3/4 of the balloon is outside, so I'm not inflating the balloon too deep inside the pulmonary vein. And these are things that you cannot really appreciate on fluoro sometimes. So the next thing is we look for seal. So I'm getting ready to inflate the balloon. One of the techniques that we use for assessing occlusion is color Doppler. And what I'm going to show in the next 1 or 2 slides is how we assess that on color Doppler. Our routine way of doing this is by inflating the balloon, getting occlusion, and confirming proximal seal before we start freezing. So what proximal seal is that we get occlusion, we pull it off and get a leak, and then move forward as we're starting the freeze to make sure that we don't engage the vein too deep. So you can see, I'm going to go back in there. Here's the balloon. We're getting to inflate the balloon. 2/3 of the balloon is outside. You can see we have full occlusion here. I'm going to pull the whole system back now, and that's going to cause a leak. And then that's a proximal seal. I moved it forward to make sure that I'm not engaging the vein too deep. This is the balloon in the left superior. The ICE also gives you an orientation of what the balloon orientation is to the carina. You can see that there's flow from the left inferior into the back of the balloon. So sometimes you might see a lower nadir temperature because that blood is hitting the back end of that balloon. So again, gives you the orientation. So another way that we check for occlusion is with a pressure monitoring. So what we do is we don't have contrast on our manifold setup. The manifold is connected to the cryo balloon, to the inner lumen. And what we have is we have a pressure line, and we have saline irrigation. We usually have the third port capped. We don't routinely use contrast for our occlusion strategies. So what we are looking for when you have no occlusion, when the lumen is completely open to the left atrium, you're going to see an A and a V wave. And when you have, and there's your A and a V wave, as you see, there's no occlusion. When you inflate the balloon and you have, say, a small leak, you're going to see a small A wave and a large V wave. But when you achieve complete occlusion, you're going to just see the V wave. And I'm going to demonstrate it in the case. So here's where we're starting. This is what our hemodynamic screen looks like. You can see the A and the V wave, and you're going to see me inflate the balloon and this pressure recording changing to a V wave. So here we are starting to see the V wave here. And what I like about this technique is that if I say didn't have occlusion, I will move the balloon. I can look on ice and decide whether I need to curve it more, rotate it counterclock, rotate it clockwise, whatever I need to get occlusion, I can do it real time. Whereas if you're using contrast, you have to move the balloon, inject contrast or puff contrast and see if you have occlusion. And if you don't have occlusion, move on along. Whereas this is more real-time occlusion. Whereas the minute you get occlusion, you know that you have occlusion. For example, here you had a small A wave, so I'm moving the balloon. You can see there's some noise on the screen. And once I've achieved that occlusion, right there, you have that clean V wave signal that tells me that I have adequate occlusion. So I confirm this, and I confirm my location of the balloon on ice before I come on the freeze. I also make sure that I have adequate proximal seal before I come on freeze as well. So again, demonstrating that pressure wave occlusion that we see with the balloon. So how do we show proximal seal? So we'll start off with the A and the V wave. We will inflate the balloon. We will occlude it. And what you will see me is pull the whole system back, show a leak on the pressure system. And then as we come on freeze, we move forward. Because as the Medtronic balloon comes on freeze, it actually gets a little bit bigger, and we don't want it to kind of push up. So here's where we are in the LA waveform. We have inflated the balloon. You can see we have good occlusion there. What I'm going to do is pull it all back. You can see I have a big leak, and then I move the whole thing forward as I come on freeze to make sure that I have occlusion. One of the other advantages of this technique is that as you come on freeze, sometimes because the balloon changes its PSI, its pressure, you can actually lose occlusion. And if you're using contrast, you're not going to know that you lost occlusion. Whereas with the pressure system, you will know that you're maintaining that occlusion until the lumen freezes off. So this is the whole thing again from deflated. You can see the deflated balloon, and we're going to inflate the balloon again. Here it comes. So here we're getting ready. We're orienting the balloon in the axis of the pulmonary vein. We have inflated the balloon. You can see we have full occlusion. We're going to pull the whole system back and cause a leak before we come on full freeze. So we'll wait on that. Here we have adjusted it. We're looking on ice to make sure we're enteral. So it's not just one technique. We're combining all of that. I have pulled the whole system back. I've crossed a leak, and then I'm going forward and causing occlusion as I'm coming on freeze. In this way, I always avoid any kind of deep occlusion of the vein and any kind of issues with pulmonary vein stenosis. One of the other advantages that I also see with the pressure system is that as I thaw the balloon, it tells me if my balloon stayed occluded. So this is an example where as I'm thawing the balloon has finished its freeze, it's thawing, and as the lumen opens up, you're going to see that I came back occluded, which means I maintained my contact with the pulmonary vein antrum. And so that's also another thing that gives me confirmation that I maintained my contact, and I know that I had a durable lesion. So I do my dosing based on my time to isolation, based on my time to, based on whether I maintained my occlusion, time to thaw, and whether my balloon stayed occluded at the end of the thaw. So this is an example of how we move from left inferior, left superior to left inferior. This is the image from the right atrium here. You can see I will find my left inferior vein with the ice. I'm going to curve the sheath on the flex sheath, and I'm going to direct my Cs catheter into that left inferior pulmonary vein. I'm going to show you the same thing with in the left atrium. You can see I'm curving my flex sheath. You can see the left inferior pulmonary vein. You can see that inferior branch that I want to go into, and I'm going to send my Cs into that inferior branch of that left inferior to get the most coaxiality. You can see the balloon here with a small leak inferiorly. And what I use to cover this leak is usually the deflection on the balloon rather than the sheath. If it's a tiny leak, you can actually use the deflection on the balloon. And you can see the orientation of the balloon in relationship to the left superior. You can see how that balloon is nice and antral and covering the carina as well. So while I'm freezing the left inferior pulmonary vein, as the balloon, as we finish the thaw, now we're getting ready to move the pacing catheter into the SVC for phrenic nerve. So you'll see me move it on the mapping system coming out of the CS, and we'll take it into the SVC, and you'll see that catheter go into the SVC on ice as well. And what we do is we map where the phrenic nerve activity is. Here we're taking it out, and we find where the phrenic nerve activity is, and we tag that spot on the mapping system. So while we're doing the ablation, say if the catheter moves, we will actually know that we moved the catheter, we know where to get back to or where we tagged the phrenic nerve activity. So here we're getting ready to do a right inferior occlusion. This is from the left side. You can see the right inferior vein. You can see my achieve going into that inferior branch. You'll see me bring the balloon in. You'll see me how coaxial I am with the sheath and the balloon going into the right inferior pulmonary vein. I have inflated the balloon. There's an inferior leak, which is the most common area. I'm going to make sure I have enough curve on my sheath and enough inferior deflection on my balloon to cause that full occlusion. And once I know I have full occlusion, I come on freeze. After we've done the right inferior, we move on to the right superior. You can see this is the imaging of the right superior. You can see the clear image of the achieve coming into that superior branch of the right superior. And once we have engaged the superior branch of the right superior, we will come in with the balloon and make sure that we are not too deep in the right superior pulmonary vein. Here's the example of where the balloon is inflated. You can see the balloon is occluding. I'm going to pull the whole system back, make sure that I cause a leak, and I move it forward as the balloon freezes to avoid any kind of deep freeze within the right superior, which is one of the main things that will help avoid any kind of phrenic nerve injury. One of the other cool things that we do is to assess the phrenic nerve activity by pacing, by assessing the liver capsule pulse Doppler. So I'll go over this here. We actually move, if the ice catheter is in the right atrium, I'll move the ice catheter back into the IVC, and I will look at the liver capsule, and we actually do a pulse Doppler of the liver capsule to assess the phrenic nerve activity. And here we're going to start pulse Doppling right there. You can see this is in the IVC-RA junction, rotate with the ice catheter rotated towards the liver. You can see that activity. I'm going to show this again real quick here. Here is live case. This is how the setup looks. You can see we are monitoring the phrenic nerve activity, and we have an amplitude that we're monitoring. So this is a little more, well, we use it more often than we use CMAP, because this is, for us, is more sensitive than the CMAP, especially in an obese patient. This is extremely useful. Here you can see we're in the IVC looking at the liver. We are pulse Doppling that capsule. You can see the activity. You can put a line up, and then you can kind of monitor, make sure that this is not getting low. So for example, in this case, see, we have starting to have some phrenic nerve injury. What we have seen is that we would see this decrement in the pulse capsule, on the pulse Doppler, before we even see anything on palpation. So this will actually help you identify any kind of phrenic nerve injury way before you lose any palpable activity. Once we are done with the right veins, we do a quick post-validation map. Again, it's just using the Cs catheter, mainly to see how wide our antrum is and if we need any additional ablation to get a wider antrum. So once we do our validation map, Again, when we do the validation map, we confirm the antrum with ice as well. You can see here's my achieve. I know where my ostium is very clearly, and I can map in and around the ostium to make sure that I have a pretty good antral map. This is an example of a recent case that we did. What I wanted to show of this case is you can obviously see it's a very complex pulmonary vein anatomy, is that we routinely do the balloon with no fluoroscopy and just ice and mapping, even for these complex anatomies, because you can clearly see those veins on ice and you can actually map these out with your Cs catheter on the 3D mapping system. So in pretty much in summary, what you've seen is how we integrate 3D mapping and intracardiac echo and bring in our PV occlusion strategies together to get that low fluoroscopy technique. So to summarize, PV isolation using cryoballoon has evolved as a relatively simple alternative to point-by-point RF ablation and allows for PV isolation in almost a single application in many cases. Sometimes we do a segmental approach to get a wider antrum. We have seen improved overall procedural success. We see reduced overall post-procedure complications and definitely better patient satisfaction scores during, especially with the cryo procedures. We have definitely seen shortened procedure times and left atrial dwell times. I was always asked whether if our procedure times are longer when we don't use fluoroscopy. We actually feel like we are much quicker when we don't use fluoroscopy and just use ice and mapping, because ice is such a much better way to look at where your balloon is and how you're orienting your balloon rather than just two-dimensional fluoroscopy. You can complete the whole procedure safely and effectively with the combination of intracardiac echo and 3D mapping with no fluoroscopy and no contrast in almost all cases if need. Thank you. And at this point, I'll take any questions.
Thank you so much, Devi. That was a wonderful lecture, and thank you so much for taking time to record these cases. And I think she has to go for another meeting. I would like to open this for questions right away. Dheeraj, you have any?
Hi, Devi.
Hello, Dheeraj.
Hi, how are you doing? We seem to meet each other virtually in all meetings now. We should probably meet face to face sometime. So I really enjoyed your lecture as always. I always call Devi the Rolls-Royce approach of Af Ablation, in that it was incredible. You know, obviously we always want to minimize fluoroscopy. We always think of it as a silent killer in the cath lab. And it's incredible how you managed to completely eradicate it from a procedure which is largely dependent upon fluoroscopy. Now, in case, if my only question really relates to the learning curve, how many cases did it take for you to get to where you are now?
So that's a great question. You know, I'm a late adopter of cryo. I was 100% RF user until about 2017, mostly because I wasn't a fan of the first generation balloon. And the current balloon obviously is an extremely good balloon and gives a very durable lesion, which kind of made me kind of navigate towards a cryo for my paroxysmal AF cases. So I would say the first, you know, I've always done low fluoroscopy or no fluoroscopy for most of my RF ablations. And that was one of the things that kind of kept me away from cryo, is that it was such a fluoroscopy dependent procedure when I started. So it took me, I would say, a good 6 months. I have to say that, you know, I learned with fluoroscopy. So and I know it's being just launched in India. So I would encourage that everybody learn the technique with fluoroscopy, get a feel for what that balloon does. You know, what is the movement that happens with the sheet? What are the common leak areas? You know, what are the maneuvers you have to do to get to that occlusion? But after the first few cases, possibly start integrating maybe the pressure recording and get a feel for what the pressure recording does. Validate it yourself. I mean, I did a lot of validation to make sure I had occlusion with the pressure recording and contrast before I completely went on to that. And as I said in the talk, there are some advantages to using just pressure, obviously. But I would say, you know, one step at a time. I would say losing the transeptal part is probably the last thing you want to do. You know, a few seconds of fluoro doesn't really hurt anyone. For me, it was mostly going to a lead-free approach. So we don't use lead for any of our ablations. And that's the key for us, is that, you know, we have good retainment of lab staff, and trying to avoid orthopedic problems. My back's already hurting. So that's the main thing for us to go to complete elimination of fluoroscopy is getting that lead off of us.
I agree. Somebody who suffered from back problems, I completely agree with you. Fantastic talk, a really good approach. Congratulations.
Thank you, Dheeraj.
Amit, Anil, you have it.
Yeah, can I ask a question? Devi, excellent talk. I just have one question. Do you use any deflection tool for esophagus along with this approach?
So I don't routinely use deflection probes. I used to use a single point temperature probe. We don't routinely actually even put a temperature probe anymore for our cryo cases. The things that I look for are I don't ever put the balloon deep. I watch the esophagus on ice. You can clearly see the esophagus on ice. I tried to avoid unnecessary lesions. So I heard a question early on in this session about, what if I don't get time to isolation by 60 seconds? I don't routinely just keep on freezing. If I don't get isolation by 40 seconds, I come off. And I will reposition the balloon, and I will aim for time to isolation if I have signals, unless I'm looking for a segmental approach. So I don't really freeze over the same area over and over. I try to avoid unnecessary lesions. And it's a rare thing to see the temperature in the esophagus go down that deep unless you're, doing multiple lesions and doing too deep of a lesion.
Thank you. Thank you.
Absolutely.
Very fantastic workflow integration, and it's amazing how well you do your cases. In the Indian context, the availability of the ICE catheter and cost of ICE is a consideration. How well do you think in your workflow can we replace it with a transesophageal echo? Would the left atrial, the pulmonary vein imaging would be as good or, good enough?
So my biggest concern about a TE probe in the esophagus during any kind of Af ablation is that I feel like it brings the esophagus closer to the left atrium in some way. And so if you do it, I would say that you occlude and you pull the probe back and then freeze rather than leave the probe in place, because I would worry about the probe making the distance a little short.
And it's amazing that you've reached a stage where you have same-day discharge of your patients. So if I may ask, what is the average procedure time in your cryoablation cases?
So our average times are about 40 minutes with no fluoroscopy. We usually we'll do about 4 to 5 cases in the morning. And by noon, our cryo cases are done. Patients go home the same day. I do use venous closure. So I use Perclose. So the patients ambulate within 30 minutes and they usually go home in 2 to 3 hours.
Wonderful. Thank you.
Thank you.
Thank you very much, Devi. And it's indeed my pleasure to invite Dr. Pelosi, who's Professor of Cardiology and Director of Electrophysiology at University of Michigan, Ann Arbor. I'll ask his former fellow, Dr. Auris Atreya, to introduce him. Thank you very much for joining us, Dr. Pelosi.
It's a great. It's my great pleasure to have Dr. Pelosi here on this forum with us. So I learned all my cryoballoon from Dr. Pelosi. He's been at the University of Michigan for the last 2+ decades and been involved in all of these early Afib studies, and I think has really taken to cryo. At least one of the objectives being to teach fellows cryoablation in the otherwise other house of Michigan. He's also been very actively involved in the development and the first-in-human use of some of these other cryo catheters like the LP. So it's going to be great to have him talk about using cryo for persistent AF ablation. Thanks, Dr. Pelosi, for joining us today.
Thank you, Ars, and it's always a pleasure to see you. And thank you, Dr. Narasimha and Dr. Kaur, for inviting me. It's a great honor for me to attend your conference. So we can go ahead and proceed. Let's see here. Got to share a screen. Can you see that?
Not yet.
Not yet.
So if you're having issues sharing your screen, we have your slides here.
Okay, just give me one moment. Any luck?
Yep. Please go ahead. Thanks.
Okay. Well, again, thank you for inviting me. My name is Frank Pelosi. I'm with the University of Michigan. And today I've been invited to talk to you about using cryoballoon ablation for persistent atrial fibrillation. This may have already been presented earlier, but the cryoballoon design is a two-balloon design, an outer compliant balloon and then an inner non-compliant balloon. I think one of the important points of the balloon is also understanding where the thermocouple is. It's located in the back of the balloon. So you're really not seeing temperature at the balloon interface with the tissue, but actually at the back of the balloon, which can be affected by flows from other veins that have been demonstrated from previous lectures. We've already kind of gone through this before, but the balloon is positioned through the vein. It could be verified by either fluoroscopy with IV contrast or ultrasound, which Debbie has so elegantly presented earlier today. And so this is usually what the balloon has been used for, to perform pulmonary vein isolation. But there may be a role for using the balloon, the treatment of persistent atrial fibrillation. Again, you may have seen these slides before, but the balloon offers the opportunity to deliver a more uniform, broader lesion than one would find with point-by-point RF isolation. And I think for paroxysmal atrial fibrillation, I think we can all say that in experienced hands, either technique would be suitable, but cryoballoon does offer the opportunity to perform essentially a one-shot ablation lesion. Now, as we know, for paroxysmal atrial fibrillation, it's largely pulmonary vein based, but there may be also opportunities to position the balloon in other areas outside of the pulmonary veins to improve the geometry of your ablation lesions, get a larger area, and perhaps improve outcomes. The balloon technology has evolved. Obviously, the earliest iteration of the cryoballoon is here on the far left of your screen. It had 4 jet ports, but the Arctic Front Advance with 8 jet ports offers the opportunity to give a more homogeneous cryoablation lesion. The Arctic Front Advance Pro has a shorter snout, which can make the balloon more maneuverable, and offers the opportunity to pull the achieve back so you can see isolation of the veins more easily. The Arctic Front Advance has clearly been shown to improve outcomes and arrhythmia-free results, and pretty much this has moved Arctic Front Advance to the forefront of cryoballoon and has put it on par with other ablation techniques in terms of success. So for many years, in the United States, the FDA has approved the cryoballoon for paroxysmal symptomatic atrial fibrillation. And with the large number of patients that we have with persistent atrial fibrillation, there are many that have reported their outcomes in single center experiences with the persistent population. As many of you know, other areas outside the pulmonary veins may be needed to be ablated in order to improve the outcomes with this challenging arrhythmia. As you can see here, most of the outcomes have ranged from as few as 40 or 50 patients to as high as 400 patients. Probably the variability here is really due to how rigorous follow-up is performed. For many, they may do intermittent telemetry monitoring, periodic Holters or EKGs, and certainly the emergence of implantable monitors has been an important tool for us to evaluate arrhythmia burden and its associated symptoms. Probably the most important study was to present these findings in the persistent population is the STOP Persistent AF trial. It was a multi-center single-arm study that really looked at the performance of cryoballoon with a predetermined efficacy point of 40%. Again, multi-center trial, 165 patients. The pre-specified endpoints were greater than 40% efficacy with less than 13% safety measures to avoid adverse events. Unlike previous studies, this had a very rigorous follow-up protocol where weekly transtelephonic monitoring was performed by the patients over the course of a year. And as you can see here, the efficacy in terms of freedom of all atrial arrhythmias lasting longer than 30 seconds at 12 months was 54%. So very good outcomes in a very challenging population. Of course, a 90-day blanking period is customary with these studies because of the potential for early recurrence that we can see with either cryoballoon or RF. The safety profile in the protocol was actually very good. 0.6% safety event rate, largely limited to vascular complications. Very unusual to see tamponade with this type of case. And also pulmonary vein, phrenic nerve injury was mitigated as well with some of the advanced monitoring techniques that have been described previously today. I think one of the important things to think about when you're trying to consider adopting cryoballoon in your practice is many experienced ablation physicians who use RF, particularly for Afib a lot, will tell you that my results are good enough, or just as good with cryoballoon and RF, and they may be right. I think probably the attractiveness of cryoballoon is the relatively short learning curve that you can achieve with using the cryoballoon. And I think the other thing it also brings is consistent results, both within your practice and across your institution. This is a very interesting study using French registry data that was published in Europace in 2017. Now, this is in the paroxysmal atrial fibrillation ablation population. And these patients had 24-hour monitors every 3 months. And again, efficacy was felt to be less than 30 seconds of AFib or atrial flutter or atrial tachycardia. And you can see here on the left that the population or the group with cryoballoon had a very uniformly consistent efficacy in terms of freedom from AFib or atrial tachycardia, but there's considerable variability on the curve on the right. And this is largely based on the volume of the centers that treated this particular arrhythmia. As you can see in the lower right-hand corner, there is the higher volume centers had actually better outcomes than the lower volume centers. And this is also confirmed by looking at individual operators. This is the curves for individual operators using the same data. And you can see with cryoballoon, you have much more consistent results, even for people who are not doing a lot of these types of procedures per year. And much more variable results with radiofrequency ablation. As many of us who do RF ablation for atrial fibrillation, and I still do it occasionally, and I had been doing it prior to adopting cryoballoon in 2012. There are many of us who have had experiences where we feel like we've had a really good outcome, and 3 months later, AFib comes back, and we're scratching our head as to what we would have done differently. I feel like with cryoballoon, when we feel confident that we've isolated the veins, we almost uniformly get a really good result. If patients do recur and they need to be brought back to the lab, it's usually just a small area around the veins that may need some work, or perhaps ablating areas outside the vein to give us a wider antrum of ablation to prevent recurrence. This is an interesting study that was published in 2015 by Ken Ellenbogen's group in Richmond, Virginia. And in this study, they tried to basically quantify the amount of tissue that was ablated in the posterior wall with a conventional, one-shot posterior pulmonary vein isolation. And what they were able to demonstrate is that over 70% of the posterior wall was successfully ablated with the cryo balloon. So you can see here on the right, post-ablation, the gray area are the areas of the veins, the posterior wall that is really quite well ablated with very low voltage in that area compared to the pre-ablation lesions. And this is an example of a case that we did in our lab not too long ago, where we're able to show with a high-density map that we performed after the ablation, just the degree of incredibly low voltage that you get with cryo balloon. And I find these results to be quite persistent. I mean, even when we bring patients back for repeat procedures, I don't even use the cryo balloon anymore because most of the veins are isolated. And it's very rare that I would see a situation where a large portion of any individual vein would need to be reablated with cryo balloon. And this is after 6, 7, 8 years after ablation, which is a bit different than RF. The RF, over the years, I've seen patients that come back 2, 3 years out where their maps look like they haven't been ablated. So this is also another high-density map that we performed where we looked at the role of the roof line. Now, for many of us that feel like we need to do extra lesions in addition to pulmonary vein isolation, looking at the roof line is actually, I think, very helpful. If you can see, if I can just slow this down, if you look on the image on the right, you can see how from pacing the posterior wall, we're actually seeing collision along the roof. You can see how the two sets of arrows are colliding here. And this is an area where there's usually a lot of fractionation, discordant electrical conduction, and perhaps an important area of the heart to make sure is well isolated or well ablated to suppress recurrence. So this is also studied by Nambu, published last 2 years ago in JCE, where they took 81 consecutive patients. The 31 were PVI only, and the subsequent 50 were posterior wall isolation with cryo balloon. And they looked at the results of patients who had both incomplete and complete block. Now, in the slide in the upper left and the lower left, you can see, or excuse me, the upper left and the upper right, you can see where there's incomplete roof block, where you can see areas of conduction occurring in this area. The panel in the lower panel is an example of a patient who has complete roof block. This is done by pulling the balloon back, leaving the achieve into the vein as an anchoring point, and gradually pulling the balloon back and rotating it either clockwise for the left-sided pulmonary veins and counterclockwise for the right-sided pulmonary veins to give a little bit more of a posterior orientation and to eliminate the signals coming along the roof. And as you can see here, in the patients who had roofline block, they had much better arrhythmia-free survivals versus patients who had evidence of roofline conduction. Roofline block or conduction was not considered an endpoint for the procedure, so they were able to look at the impact of a roofline block in improving outcomes with persistent Afib patients. Many of us are very interested in the role of the posterior wall. And we are increasingly using posterior wall isolation as an adjunct for patients, particularly with persistent atrial fibrillation or who require a repeat procedure. Ariana and his group out of Austin, but it was a part of a multi-center trial and the senior author was Andre Natali there in Austin, reported their findings of a multi-center study where they took 390 consecutive patients. The first 168 were pulmonary vein isolation, and 222 were pulmonary vein isolation and posterior wall isolation. Adjunct RF was allowed if after performing the cryoballoon ablation of the posterior wall was achieved, you still did not have adequate posterior wall isolation. 50% of these patients did undergo a cavo tricuspid isthmus ablation if they had coexisting right atrial flutter. This is a busy slide, but it does demonstrate the techniques that are used to perform the posterior wall isolation. And it largely is based on using the Achieve catheter to anchor the catheter in the pulmonary vein and using it as a pivot point to position your balloon. You can see it's some of these fluoroscopy images do look a little scary, but I can assure you that this can be done quite safely and without, as long as the balloon remains inflated, is relatively safe in terms of perforation risk. And they had very few adverse events with this study. Also, one can use intracardiac echo to position the veins. In this study, they used a cardio mapping system combined with ultrasound to annotate the location of the ablation lesions. And you can see here, the blue circles represent the equator of the balloon as it's being positioned around the vein. In the right upper panel, you see a very well isolated posterior wall with a very low voltage, dense area of the, which is indicated by the red area. In the lower left-hand panel, you can see there was some posterior wall activity during the ablation, and in the lower right-hand panel where you see the arrow, some RF lesions were required to successfully perform the posterior wall isolation. And their outcomes were quite good. Freedom from all arrhythmias, as we mentioned before, including atrial tachycardia, flutter, or fibrillation, were on the order of approximately 75% where posterior wall isolation was used as an adjunct to pulmonary vein isolation. Why can cryoballoon work so well in this situation? I think it's a combination of things. As many of us know with RF, your contact is a very important factor that we have to take into consideration. And I think contact force technology has helped with ensuring a stable catheter during the ablation. I think the fact that the cryoballoon adheres to the tissue also provides stability, and you're also providing a longer lesion than you would with radiofrequency ablation. One of the challenges of radiofrequency ablation, in my view, is how do you know you've created a good lesion? And I think with a cryoballoon, knowing that you're making contact and you're seeing temperature drops, even if you're seeing a temperature drop in the esophagus, as long as it remains modest, you can ensure that you're delivering cryoablation energy to the tissue. And I think, again, it provides an added measure of stability and a more durable lesion over a larger area. Well, that's about all I have, but thank you very much for your time and inviting me
Yeah, thank you, Frank. Excellent talk. It's really interesting to see how posterior wall isolation can be achieved with the cryoballoon as an additional procedure. I have a couple of questions. What measures do you take to protect the esophagus? I saw the images and there were many lesions given on the posterior wall. So how do you protect the posterior esophagus? And secondly, which are the cases where you, how do you select cases to perform posterior wall isolation in addition to the PV isolation?
Well, in terms of, sorry, there's a little bit of a delay in hearing you, so I'll proceed. What we usually do is we use a multipolar probe in the esophagus, and usually the our temperatures above 3 centigrade, but the one thing I have noticed even when we come off the balloon at 5 drops going down maybe 4 or 5 years. We don't use any tools to manipulate the esophagus. We never need tools to manipulate. And I find that you much have a greater margin with cryo we would have. And with regards to patient selection, we usually do pulmonary vein isolation only. I will posterior not a full posterior wall isolation, largely to get a large antrum after I'm hitting areas back to Bida, Carolina. And then I will, for persistence, I will do a high density map to ensure that I have a large ablation lesion set. If we do bring patients back for repeat procedures, then I will do a full posterior wall isolation. I will also do posterior wall isolation for patients who have long-standing persistent atrial fibrillation, who may be in Afib for maybe a year or so. Many of those patients have a substrate-based physiology as well as a pulmonary vein-triggered physiology. So I think isolating the posterior wall in those patients is particularly helpful.
Thank you.
Thank you very much, Dr. Pelosi.
Any other question? Amit, do you want to ask any question? Dr. Simon, any comment from your side?
No, I would like to.
Amit, do you have any question?
No, I think it's a tremendous technology, and there is going to be an increasing evidence. Going to be an evidence. Sorry. Can you mute yourself 1 second? Yeah, I think this is an emerging technology, and we'll have more evidence that it's as good as RF even in persistent atrial fibrillation. Because the cornerstone, even in persistent atrial fibrillation, seems to be durable PVI. And what is lacking is clinical evidence. I think over the next couple of years, we'll have large randomized trials providing this evidence. Thank you so much for taking the time and for the wonderful presentation. Thank you so much, Dr. Pelosi.
Thank you so much for having me.
I think we'll have the next talk by Dr. Dheeraj Gupta, who's heading the Afib Alliance in terms of improving the outcomes of atrial fibrillation management in the UK. And he has spearheaded this systematically to kind of democratize the process of Afib ablation. And by kind of bringing it to every fellow and standardizing the procedure so that the outcomes are more or less the same in everyone's hands. We have seen him in the morning operate, and we are really lucky to have him. And he's an excellent teacher, and he's going to walk us through some of the difficulties in cryoballoon ablation and how to overcome them. Dheeraj, please.
Thank you. Thank you, Dr. Narasimhan, for the very kind words, very kind introduction, and most importantly for the invitation to come to Hyderabad and enjoy your hospitality. I have learned so much today, and I look forward to learning some more tomorrow as well. I've been asked to speak about troubleshooting for cryoballoon pulmonary vein isolation. Now, part of the appeal with cryoballoon pulmonary vein isolation is that you do not need much troubleshooting. It is a very simple approach to master because the learning curve is so short. So what I'm going to be doing in the next few minutes is to go over some of the so-called troubles that you might face in the catheter laboratory, especially early on in your learning curve, and how you might get out of those troubles, as it were. So what kind of troubles can you encounter in your first few cases with cryoballoon? First of all, it's important to reiterate that the most common complications from AF ablation continue to be vascular in nature. So So a simple solution for that is to get ultrasound guided access, and I was very impressed to see that is the standard of care here in AIG hospitals and indeed in many hospitals across the world. But that is so important, because if you have a vascular complication, then a lot of your good work inside the heart can be undone by unhappiness on part of the patient. Pulmonary vein variations can be an issue with any single shot technique, especially balloon-shaped ones, and cryoballoon is no different. There are various tricks that we can use to try and get around this problem, and I will briefly cover that as well. Phrenic nerve injury, we have covered that in some detail, but I will just talk about my simple, low-cost solutions to avoiding phrenic nerve injury. Last but not the least, we'll talk about esophageal injury. Thankfully, as it's extremely uncommon to see esophageal injury with cryoballoon, but it's not unheard of. And what can we do to reduce the incidence even further? First of all, a little bit about my center. I don't know how many of you have been to Liverpool or how many of you have heard about Liverpool. It's usually a city which is well known for its football. And we are doing very well right now in the league and the Champions League. But essentially, I work in a hospital there, the Liverpool Heart and Chest Hospital. And we cover a population of about 3 million in the northwest of England, and we cover about 10 district general hospitals who refer patients to us. The reason I'm telling you all this is it's going to put our practice in context, so how that has changed over the years since cryoballoon has made an appearance about 10 years ago. So we are one of the largest, if not the largest center in the United Kingdom. We do about 1,500 cases a year and have done so for many years now. Now, one of the issues with radiofrequency AF ablation is that it suffers from lack of standardization. What we really want to achieve is something that looks like a map on this screen. So really nice contiguous lesions. We have good quality burns all the way through. No need for any additional ablation. Unfortunately, what a lot of people end up with is this. So it's a bit of a scattergun approach. You have lesions everywhere, including the carina, including the roof. And unfortunately, that is what has given radiofrequency ablation a bad name over the years. Single shot technologies have several advantages, and that's why they've become very popular. The procedures are short, and we saw that today. We also heard Dr. Devi Nair, 40 minutes procedure times. That's incredible. Even in my hands, so, clearly not that skilled as Dr. Nair, these procedures will not take more than an hour at most. So they're short, but more importantly, they're predictable. You can plan your list with confidence. You can list 5 or 6 cases a day. You know you will be done by 5 o'clock because the procedures are not going to take more than the time you've allocated for them. The learning curve is short, and most of us can get pretty skilled with cryoballoon PVI within 10, 15, 20 cases, depending upon how much background skill you have in terms of transseptal access. The setup is extremely easy. You do not need advanced 3D mapping systems. You do not need lots of physiologists to help you. And because of all of these reasons, it is often cost effective. Yes, the software and the hardware might be expensive, but if you look at the overall patient journey, including the time spent in hospital, you do save money down the line. Even in our hospital, just like Dr. Nair, in Nair Center in Arkansas, most patients go home the same day. So most Afib ablation is now performed on a same-day discharge basis. And that is the reason why cryoballoon has become so popular over the years. Now, you look at the astronomical growth in this chart over the last 10 years or so, and that figure tells its own story. And indeed, even in our hospital, our radiofrequency to cryo split has changed over the years. As you can see, over a 5-year period, we were largely a radiofrequency center, a bit like what Dr. Frank Pelosi said. A lot of our operators voted with their feet. They realized that the results perhaps with cryo were better than with radiofrequency PVI, and now they have started using cryoballoon PVI, at least for first-time procedures. Some of us still continue to use radiofrequency ablation, largely because of the flexibility it brings to your workflow. But by and large, the cryoballoon PVI is becoming increasingly popular. Large randomized controlled trials have shown that both cryoballoon and radiofrequency PVI are equally efficacious. Whether that was using the first generation cryoballoon versus non-contact force sensing catheters, as was studied in Fire and Ice study, or the second generation cryoballoon with contact force sensing catheters, as was studied in more contemporary Circa-dose study. However, the real-term results are very different, and this is exactly what Dr. Pelosi showed. I was a part of this study by Rui Providencia, performed in Europe, and it was a survey of AF ablation results in various centers in Europe, depending upon the experience levels of the operators and the experience levels of the institution. And what was striking is we saw that the variation was so much more marked with radiofrequency as compared to with cryoballoon. So if you look at the success rate with cryoballoon, it's a very narrow spectrum. So it doesn't matter how less experienced you are likely to get success rates at least in 60% of your PAF patients. If you're very experienced, that can go up to 80%. But look at the variation in the success rates in radiofrequency ablation. Depending upon how experienced you are, your success rates could be as poor as 30%. And for that reason, a cryoballoon PVR is particularly useful in operators whose procedural volumes are perhaps going to be modest, say less than 50 per year. Now, we have tried to standardize radiofrequency AF ablation over the years, and we did do one radiofrequency AF PVR case today as well, just to highlight some of the things that you can do to try and improve success rates across operators, such as using general anesthesia, using steerable sheath, using objective lesion tagging, intraocular distance, etc. But still, there is a steep learning curve, and it does require a certain level of commitment on part of the operator to continue to do these cases on a regular basis so as to maintain those levels of skill. Indeed, a lot of these standardization have resulted in improved successes, and we've shown that over the years, not only for paroxysmal, but also in persistent atrial fibrillation, where you can get really good success rates if you were to use the standardized radiofrequency approach using even high power, such as 50 volts. And we also know that protocol is reproducible across a whole range of operators, as we showed recently in this closed study, in this VISTAC study, which was published a couple of years ago. So depending upon how experienced the operators were, there were some differences in radiofrequency time and procedure time, but overall success rates were still pretty good. The most important thing is to avoid a vascular complication. And I can't stress highly enough how the time for doing blind venous punctures is over. In the UK, it's medico-legally indefensible to do a blind puncture, and with good reason. When you can see something, why should you do it blind? It really makes the procedure so much more straightforward to get access to once you have the ultrasound, and it really doesn't add to the procedure time at all. And this is a typical sort of X-ray based procedure that we will do. We really do rely on getting good seal using contrast, as you can see here. Although you can use the pressure monitoring as well, as Dr. Nair said. We don't tend to use ICE regularly in the UK, not in our center, but indeed any center in the UK, largely because of cost reasons. But we use a combination of contrast injection as well as the pressure waveform. And you can see we also rely very heavily on the trajectory of the temperature drop. So if the temperature is dropping promptly and very well, as you can see here, usually we say if you reach minus 30 degrees at 30 seconds, you've got a very good seal and you're going to get a very good end result. So we look at that, and that guides us very nicely. If we don't get a good seal, i.e., or if you don't get a good temperature drop, if you don't reach minus 40 degrees by 60 seconds, we would stop. We would re-occlude the balloon and we would go again. It's better to get one excellent quality freeze rather than lots of mediocre level ones. We also look at the pulmonary vein signals in real time on the Cs catheter, and that allows us to look at the time to isolation and also allows us to tailor the exact cryoablation time. So we usually add 120 seconds to the time from isolation. And again, this is another example. This is the left lower pulmonary vein. We've got a very good seal here, you can see, and we can see a dissociated pulmonary vein potential here. And we saw quite a few of those in the cases that we did today as well. So in this particular case, procedure time was 70 minutes. Again, a bit like the example at Little Rock, we mobilize after 2 hours and patients go home the same day. That really should be the gold standard now, to get patients in and out of hospital as soon as possible. And what COVID has done is it has just turbocharged that process, which was underway for the previous couple of years anyway. And that really is our patient journey pre and post procedure, in which patients come in the morning and have the ablation procedure, the uninterrupted oral anticoagulation, and they go home the same evening. The other issue with balloon-based technology is anatomical pulmonary variance. Obviously, when you have the flexibility of radio frequency, it doesn't matter what kind of anatomy you have, you can deal with it. But with the balloon, you've got that you always have that concern at the back of your mind, especially a left common pulmonary vein, which is not an unusual anatomical variation. About 1 in probably 12 patients, 1 in 10 patients will have a left common pulmonary vein. And there's always been concern whether or not that will result in suboptimal results with cryoballoon PVI. Actually, it hasn't. And lots of people have looked at their results with a left common pulmonary vein anatomy, including this paper, which was published back in 2017. There have been lots of subsequent papers as well, in which they have seen that if you have a left common pulmonary vein, you can achieve isolation either more distally by selectively engaging the branches of the left common pulmonary vein, or you can even do it proximally by a so-called segmental approach. I won't lie, it is more challenging to be able to successfully get antral isolation of a large left common pulmonary vein, because the balloon is 28 millimeters. It's going to sit where the diameter of the orifice is 28 millimeters. But there are various ways you can try and improve your success rates by ensuring that the orientation, the alignment of the assembly and the vein is as coaxial as possible. So we can do that by selectively engaging the various branches of the pulmonary veins. You want to make sure that your alignment is as coaxial rather than this way. And once again, you learn this very, very early on. The learning curve really isn't that large. Within 5 or 10 cases, you realize that you get much better seals, much better temperature drop behavior if you're aligning the balloon to the alignment of the pulmonary vein. What about phrenic nerve injury? This is probably, in my mind, the biggest source of concern, if you like, during a cryoballoon PVI procedure. The whole procedure takes only about an hour. But it's for those 5 or 10 minutes when I'm isolating the right side of the pulmonary veins that I'm most concerned about. That's when my sensitivity is the most heightened, because I really want to avoid this complication as far as possible. This is excellent animals work done by Jason Andrade's many years ago, in which they looked at the histopathology of cryoballoon ablation-induced phrenic nerve injury. And what they showed was that the pathophysiology was axonal degeneration rather than demyelination. And that explains why when you get phrenic nerve injury, it's typically typically manifested by loss of contractile function. First, you have diminution of contractile function, then you have loss of function. It's not this delay in the contractile function. It's just decreased amplitude. They also showed that this effect, this injury, is centripetal. So for the initial bit, it's a mild one or even moderate injury, you can reverse it if you act quickly enough. It's only in grade 3 or severe injury where the complete nerve has been lost. Only then do you have irreversible injury. And I'm pleased to say that that is not extremely rare. I mean, we've done cryoballoon PVI for a decade in Liverpool, and I don't remember the last time we had a permanent phrenic nerve injury which did not resolve. And so it's important to have some standard definitions about phrenic nerve injury. You can have transient phrenic nerve injury, which is resolved before the end of the procedure or before the patient goes home. That's really of no concern. You can have phrenic nerve injury which is not resolved by discharge, but often goes away by the time you see the patient in a month or so. And then sometimes, very rarely, as I say, you can have persistent phrenic nerve injury, but it doesn't resolve by 12 months. And that really is what you want to try and avoid. How can you do so? So first of all, the most important rule is to avoid a distal positioning of the cryoballoon. I'm going to show you some examples how you can do that. Secondly, you want to perform electromyography of the diaphragm using phrenic nerve pacing. And again, we'll see a few images. You want to reduce the freeze time as much as possible. So the time for bonus freezes is over. You want to have, as I said, quality over quantity. If you have a really good quality freeze with good early isolation, you want to stop at 180 seconds, especially for the right-sided pulmonary veins. You want to monitor the rate of temperature descent like a hawk. If you get a very rapid temperature rise, temperature fall, it means that you're too deep inside the vein. And certainly if you reach minus 60 degrees Celsius at any time, you really want to come off the freeze as soon as possible. And also, if you have any sign of phrenic nerve injury, you want to not only stop the nitrous oxide delivery into the balloon, but you want to come off the balloon inflations immediately. So you can have a double off, or in the more recent consoles, it's just a case of pressing that off button for a long time. Essentially what that does is it not only stops the flow of refrigerant into the balloon, but also collapses the balloon at the same time. So let's go into this in a bit more detail. How do you know that you've gone too distal in the cryo balloon, in the pump vein, without using expensive technologies such as ICE, for example? Just simple fluoroscopy. Now, if you look at the example on the right side, the distal half of the balloon is outside the cardiac silhouette. That is too far in the vein. You're more likely to encounter the phrenic nerve. The other thing you can do is see where you are capturing the phrenic nerve from your catheter that you've placed in the subclavian. If you were to draw a straight line from that down to the balloon, if the balloon, if that line transects the north pole of your cryo balloon, you know you're too far. Ideally, what you need is for the balloon to be sitting inside the cardiac silhouette. And there are ways and means you can do that. For example, if the very first time you manage to get occlusion and the balloon is too distal, you might get an excellent freeze. You will almost certainly isolate the vein very quickly, but that will come at some risk of phrenic nerve injury. In those cases, I would subselect another branch of the right upper pulmonary vein, almost accept a slightly less quality freeze for a more antral position of the balloon. So simple tricks: A, look at the silhouette of the balloon. B, look where you're capturing the phrenic nerve with the catheter in the subclavian, and go vertical from that. Make sure you are antral to it, not distal to it. And this is an example, unfortunately, in our own laboratory where one patient ended up with phrenic nerve injury. And if you see, the patient then came back and we performed a 3D mapping study. And if you see, the right upper pulmonary vein isolation is way too distal. So no, if the isolation had been performed where it should have been, which is antral at this level, then there's no reason why the phrenic nerve would have been impacted by this. So the golden rule is to avoid distal isolation. Continuous phrenic nerve pacing, absolutely important. So we did that today. I think most centers that use cryo balloon would do that. You should do it. It doesn't have to be particularly rapid, say 1,000 milliseconds. So 1 per second is acceptable to the patient. It's tolerable as well, and also gives you enough of a margin to come off should you need to do that. Also, historically, we used to pace the superior vena cava, but we now know that you get a much more stable capture if you are pacing from subclavian rather than the SVC. So we go all the way in the subclavian and we pace from there. We also don't pace from pole 1 to 2. We pace from pole 1 to 4. So that means that you've got a much larger vector of pacing, which means that even micro displacement of the catheter is not going to impede capture, because sometimes that can be a source of concern. There's a micro displacement, you lose capture, and you can't take a chance. You come off the cryo balloon, and then you realize actually it is not that there was phrenic nerve palsy. It was just that your catheter had moved subtly. So we've got around that by having a larger area through which we pace the subclavian. Electromyography, again, this is something which has been increasingly used. It gives you a visual interpretation of the diaphragmatic pacing. So it's very simple. All you do is you lead one, you swap it around. So you put the left arm here below the diaphragm, the right arm just at the base of the sternum, and essentially you're measuring the electrical activity across the right diaphragm. And that way you can see very clear signals on your EP screen. And that means that when that signal starts going down, then you know that you are losing activity of the phrenic nerve, and that is the time to stop. In fact, studies have shown that very often you get as much as 15 to 20 second time between the reduction in amplitude of the electromyogram and the palpable loss of contractility, as much as 30 seconds sometimes, and that can make all the difference between transient phrenic nerve injury, which will resolve within 10 minutes or so, to injury which may resolve over months, but it will prevent you from finishing the case. The other thing I would say is always, please, always leave the right upper pulmonary vein as the last vein to isolate. So always start with the left side, work your way to the right lower, then finish with the right upper, because the chances of phrenic nerve injury are obviously highest with the right upper. So you want to have finished as much of the ablation as before you even encounter the possibility of phrenic nerve injury. So there are different ways to monitor for phrenic nerve injury. The best thing to do would be a combination of, certainly in our lab, we do a combination of electromyography and manual palpation during phrenic nerve pacing. You can use ice, as we saw, Devi showed very elegantly. If you have access to ice and cost is not really an issue, then that would be another way in which you could do so. Monitoring rate of temperature drop is extremely important. So almost as important as looking at the signals on the achieve, you need to closely monitor the temperature drop on the console. If your temperature drop is too rapid, then that can be a sign to you that you are inside the vein and you're likely to cause damage to extracardiac structures. For example, this study showed that if you reach a temperature of -38 degrees Celsius or lower at 40 seconds, then that can predict phrenic nerve injury with a high sensitivity and specificity. So the important thing is -30 seconds at -30 degrees at 30 seconds is good. -40 degrees Celsius at 60 seconds is good. So that is the kind of trajectory you want to see. If the drop continues precipitously and you reach -38 or -40 at 40 seconds, I personally would come off. It tells me that I'm too deep inside the vein. Double off, I've already discussed that. So if you do encounter phrenic nerve injury, in spite of all of the previous 4 measures that you have used, then you have this double off technique, which almost always gets you out of trouble. And that can speed up the rise to normal temperatures considerably compared to if you were to just stop if you were to just press the stop button once and stop the refrigerant flow into the balloon. Finally, how do you minimize the risk of esophageal injury with AF ablation? You don't apply any further forward pressure that is absolutely necessary to give you a good seal. Most esophageal injury tends to happen while you're ablating the left lower pulmonary vein. That's because the esophagus lies in closest proximity to that vein. Also, histological studies have shown that the smallest or the thinnest muscle sleeves are around the left lower pulmonary vein. So you ought to be very careful when you are delivering cryo or radiofrequency energy around that vein. What we do with this is we achieve a seal with the left lower pulmonary vein, and then we know that when refrigerant will go into the balloon will increase in size gradually, suddenly from 26 to 28 millimeters. So we allow for that. So what we do is, once you've got a good seal, we pull the balloon back slightly, then turn the cryo balloon, the cryo ablation on, and at the same time just push the balloon slightly so as to get that seal again. Certainly no more forward pressure than is absolutely necessary, otherwise it'll push you towards the esophagus. Some people do a temperature monitoring. We don't, because the risk of esophageal injury with cryo balloon is exceedingly low, and we find esophageal temperature monitoring quite intrusive, especially in patients done without general anesthesia. Again, reduce the duration of energy application. A single 180-second freeze is often enough. If you're not getting a good temperature drop in the first 60 seconds, stop. Position the balloon, try again. But try to aim for a single effective freeze of 180 seconds. And with that, the incidence of esophageal injury will go down further. We use proton pump inhibitors. I think most people use them. No one's ever been able to prove whether they help or not. They certainly can't do much harm. So we would give everybody proton pump inhibitor for a month afterwards. And that is the proximal seal technique, which I just talked to you about. You get a seal and just pull the balloon back, allow a little bit of contrast to flow through, then turn the cryo on and then push the balloon further. LAT monitoring, as I said, some centers have done it, but it has largely fallen out of favor just because it has not really been shown to reduce the risk of serious esophageal complications, which are thankfully extremely rare anyway. The important thing is that all of these complications have really reduced with experience. Now, if you go into for the STOP AF study, which was published many years ago now, just look at the incidence of phrenic nerve injury. Over 1 in 8 people will have phrenic nerve injury, and that figure has now gone to more like 1 in 40 people in the more recent FIRE trial. Similarly, pulmonary vein stenosis has become extremely rare, almost unheard of, because we don't occlude the vein, we occlude the antrum. And similarly, esophageal injury as well, because the time to isolation is now often used to reduce your freezing time, you're less likely to cause ancillary extra cardiac damage as well. So important to emphasize that you want to get quality of freeze rather than just keep on stressing and doing more and more freezes if they are not necessary. To summarize, cryoballoon PVI is mostly a straightforward procedure, and I'm sure you will find out when you start trying it. Within 4 or 5 cases, you'll feel great. Within 10 cases, you'll feel invincible. You'll feel nothing much can go wrong with this. If your transeptal approach is standardized and you're used to doing transeptal for left-sided procedures such as pathways, etc., the incidence of other complications with cryoballoon is very, very rare. For example, tamponade is extremely rare. I always liken the cryoballoon to like a airbag in the car. It's almost impossible to perforate the left atrial surface with an inflated airbag. And simple steps like I have shown you can minimize most complications and make this procedure almost risk-free. I'll be very happy to take any questions.
Thank you very much, Dheeraj. It's now open for questions. Anil, Amit, any questions in the chat box others can post?
Great talk. I don't see any questions in the chat box. So, Amit, do you have any question, or any other panelist, if anybody wants to ask a question? And
I think Dheeraj has covered it so well that he's almost made the procedure and the complications that can happen easily preventable. But yes, I think so. Again, Dheeraj, let me ask you the same question: that what do you think in terms of avoiding the complication? I think that is one of the major fear, and you covered that very well. In terms of the learning curve, you said this cryo has a very short learning curve, but these complications, and you've covered them well also. But yet, I would like to ask you this: that how much is the learning curve to avoid the complications?
Sure. Well, I think for an experienced EP, somebody who's used to getting left atrial access, the learning curve is incredibly short. I would say as less as 10 cases. Now, you remember what the learning curve used to be for focal RF, for doing AF ablation. Hundreds of cases, and still you won't feel really comfortable. Whereas with cryoballoon, if you do 10 cases, you know what to do it. Of course, there will be some cases which will be difficult. Anatomy is not going to be, really favorable. But those cases are rare. By and large, the balloon does what it says on the tin. It occludes the veins and gives you safe, durable isolation. And so I would strongly recommend to people to use those simple measures that I've highlighted in my talk to reduce the risk of the phrenic nerve palsy, which is really the most common serious complication that you encounter. To use ultrasound guidance to get vascular access, which is the most common complication you encounter with AF ablation. Once you get rid of those two, there's not much else that can go wrong with the cryoballoon. There isn't really.
Is there anything new come up in terms of worst case scenario if you have a phrenic nerve palsy? What do you do for the patient?
Well, sadly, there isn't much you can do other than thoracoplasty. So the surgeons can do it. So they essentially, what they do is they tie together the parts of the phrenic nerve which have not been damaged. And success rates are reasonable, but I still believe that an ounce of prevention is better than a pound of cure. You're better off preventing it, and it's so easy to prevent.
One question, if I may. Do you have any instances where there is no phrenic nerve palsy on the table, but patient has come back with late onset of phrenic nerve palsy? Never. I've heard one or two cases where that has happened, and I found it very difficult to believe as to why. Because if you see the pathophysiology, which was covered in the very first talk today, the moment the temperature starts rising, actually there is no way in which you can cause injury after that. So much so that the moment we stop the refrigerant flow, I stop pacing and I take my hand off the abdomen, because I know that, let's say, the rest period is over. Venous closure. Yeah. So again, it depends on what you want to do. You can use the per-close device as Devi does, and that can really speed up the mobilization. Or you can do a cheap and cheerful figure of 8 suture. So if you do a ultrasound guided access, then automatically that will minimize the bleeding around the site, because you're not going to nick the artery, you're not going to kebab the vein, you're only going to go through the anterior aspect of the femoral vein. And again, unlike radio frequency where you often have 3 or 4 sheets, you're only going to get 2 sheets in. So your risk of bleeding is low anyway because of all of those reasons. And then at the end, you can do a simple figure of 8 suture. Most of our patients are mobilized. We don't use per close, we just use figure of 8 suture. Patients are mobilized in a couple of hours, and as I go home 4 hours later.
The other thing is the use of protein. Safety has been demonstrated with the randomized control trial.
Yeah, that's a very good point. Yeah, so we always use protamine for all our cases to reverse heparin that we use during the procedure.
The question is to Sai. Among any recalls or adverse events, have you had any event where there's been a movement after the balloon is frozen and there's been an injury to the left atrium? You completely need to avoid movement after the freeze. Does it tear, if they move or inadvertently move, does it tear the vein, or have there been any instances?
No, actually, on the contrary, there are some physicians that will actually move the balloon while it's frozen, even though we advise strongly against it. There have been many cases that I'm kind of helpless watching, and I'm hoping for the best, but that's never happened, luckily. I've never seen, a tear occur when somebody's moved the balloon, but for safety reasons, and of course, according to our IFU, never move the balloon after it's frozen, because, it's stuck in place. It's not like an RF catheter, which moves with your heart movement. So just ensure that, things can go wrong, but we have not seen it. So there's a potential for that to happen. However, the other thing I want to comment on is the double stop, or, that Dr. Gupta was talking about. It's important that we've already shown, because some people are skeptical about using the double stop, because they're like, okay, when you suddenly deflate the balloon, what happens, will it tear off tissue? Will you do that? It turns out that the ice actually sticks to the surface and the balloon comes off clean. So there's no real damage, and it's been demonstrated thousands of times, in cases that we use double stop pretty safely to kind of come off immediately, so that area warms up pretty quickly.
Yeah. May I just add one more thing to that as well? I think, as I said, the procedure itself is pretty low catecholamine, low stress environment in the catheter laboratory. It's pretty easy. But that one time where we are ablating the right upper pulmonary vein is the one time I like the lab to be quiet. And I want that the person who's got the button, the stop button in his control, should be only listening to me, right? So if I say stop, a double stop, I don't want there to be much of a lag. So those 3 minutes when I'm ablating the right upper pulmonary vein, it makes sense to have clear channel of communication, that the person knows exactly when you say stop, what do you mean? He stops it, because time is of essence. Even a 10-15 second delay, it can mean a difference between phrenic nerve injury that resolves within 5 minutes, or 5 weeks or longer.
There's been some question in this chat box. Amit?
So the question, and Lawrence is asking this, and I was about to ask, how often do you require RF in cases of cryo for PVI? So you've done the cryo, but how often do you require to touch up with RF ablation?
Pretty rare. I would say we probably get a couple of cases a year where we needed to do that. The reason is we don't select our patients based on CT scanning beforehand, MRI scanning. So we take on all comers, which means that sometimes you will encounter a patient who's got a weird and wonderful pulmonary vein anatomy. You might have a roof vein perhaps, or you might have a massive left common pulmonary vein, which whatever you do, the cryo balloon is not fit for purpose for that. But those cases are quite rare. Obviously, I think what the question didn't mean was how often do you need radio frequency if you want to do a flutter line or if you want to do anything else. But I think just for isolating the veins, pretty rare.
Well, I think we had a very good interaction overall. I would like to thank Medtronic for making this possible, and all the speakers, faculty who have done a wonderful job, and the chairpersons, Sai, Auris, Devi, and Dr. Pelosi, Dheeraj, and all the others. And I would like to thank all of you. We would close the session. If there are any questions you can post, we can come back and revisit those questions later on. Thank you very much and good night.
Thank you. Thank you, Narasimhan, for having.
Thank you, everyone. Thank you so much. Great session.